thank you all for coming. Can I introduce the third press event of the day? Can I first of all remind you that if you get a call and you need to go out, use the door at the back, because we'll have to keep that one locked to block the noise. Can I ask you to put your phones on silent? And I hope I've done the same. And can I introduce a very large panel of speakers, all of whom will speak very, very briefly, each of them, but as explosively as possible, on the great question of the war on drugs. And to introduce the speakers, I'm going to ask Professor Michel Kazatchkine, who's the UN Secretary General's Special Envoy on HIV/AIDS in Eastern Europe and Central Asia, to just tell you what it's all been about, and then we'll go through, the other four speakers will all get a chance to talk very briefly too, and then of course you'll get a chance to ask questions, and that's what the press conference is for. Michel.
Thank you very much, Tim. So this is about drugs, the world drug problem. And this is a hugely complex issue at the intersect between health, science, but also justice, politics, economics. It's also, as I said in the seminar earlier, I think one of the areas, or maybe to me, the area where the gap between what the science tells us we should do and what actually happens on the ground and the policies is the largest. As you know, we've lived for 50 years when it comes to illicit drugs on a regime of prohibition. When it comes to alcohol or tobacco that kill millions of people, 2.5 million per year for alcohol, as you know, 1.3 billion smokers worldwide, the world regulates these addictions with a regulatory framework for production, retail, consumption. When it comes to illicit drugs, by definition, since they are illicit, it's prohibition, criminalization, incarceration, rather than a health approach, to make it short. And that has led to an epidemic of incarceration. We'll hear from the example of Georgia, a country reflecting now on its past as one of the highest incarcerators in the world. It has led to an epidemic of violence, as we've seen in Latin America, 50,000 deaths in Mexico from the war on drugs in the last 10 years, and Mexico now changing radically its political position on this. It's been violations of human rights across the world, and it's been a major health crisis with an AIDS epidemic, an epidemic of hepatitis C, an epidemic of tuberculosis among people who use drugs. And one of the regions that is the epicenter in the world of an AIDS epidemic driven by unsafe injections is Eastern Europe. And you'll hear a few words from Dr. Klepikov of how the region is handling this, both from a policy perspective and a political perspective. And this is particularly frustrating because actually we know what to do. The science has shown us that interventions called as harm reduction, including needle exchange, provision of sterile injection equipment to people, opioid substitutive therapy for people who are dependent on opiates, antiretroviral treatment for those infected with HIV in need of treatment. The combination of those interventions, as we call harm reduction or harm minimization, is effective, so that in Western Europe, and Scotland will be one example of that because it witnessed one of the first epidemics in Western Europe, there's just the problem is solved. No people injecting drugs is actually becoming infected anymore with HIV in Western Europe. And so the reason why having this session here, I think, is twofold. One is because this is really a key example of a gap between science and policy. And second, because the UN General Assembly has called on a special session of the General Assembly of the United Nations. This will be for the first time in 20 years. This will happen in March 2016. And within a very hot political climate where Latin America is now at the forefront of the battle, where Russia, China, Iran are on the resisting side, The debate is open, and I wanted to say I wonder where Europe is in this debate. It remains silent, although it's a continent of values and a continent that prioritizes health in many of its interventions.
Thank you very much. And we'll hear from Europe first, in fact. Roy Robertson is at the Centre for Population Health Science at the University of Edinburgh. Professor Robertson.
Yeah, thank you. Yes, I'm a clinician in Edinburgh and have worked for many years with patients with drug problems. My presentation this morning was largely about how effective our intervention in the early years in 1980s.
Turn it on, please.
The 1980s and 1990s and beyond at preventing bloodborne virus spread, about particularly HIV infection. So my presentation was really just demonstrating that it can be done. Just on drugs in general, I've remained frustrated with our local national policy, with UK policy, with European policy, and with international policy on drugs, because it has been largely driven by the criminal justice agenda. And I mean, every time I ever get the opportunity, I always say it should be a health matter, and if we had it in health rather than driven by criminal justice in almost every country in the world, the lead agency is crime enforcement agencies. If we had it in health, then we would have a different perspective. We would have a caring perspective. We would have a holistic and a compassionate and an interest in people rather than in some sort of idea that you can control people's behavior by some massive global sort of diktat. So I do think that the frustration has been and remains that we're coming at this completely the wrong way, that we really do need to be interested in trying to care for people. The trouble is there's so many angles to it. You know, it overlaps with inequalities, it overlaps with all sorts of other issues, and it's hard to sum up exactly what needs to be done. But a new policy on drugs is definitely necessary, and it needs to be led by the medical establishment, I think, and the caring establishment. It isn't just clinical medicine. It's of course all the allied professions. And I think the press has an enormous part to play in all this, because I think the press certainly helped us enormously in the 1980s, telling the real story, the real spectre of what could happen in the United Kingdom. You know, this HIV epidemic could become a heterosexual epidemic, could become a pandemic of African-style transmission of HIV infection. And the press got it, and they understood that, and they influenced governments, even like the Thatcher government, which wasn't easily influenced on caring, sharing social issues. So I think your role is critical and crucial, and I think there's very many things you can do now, in between now and the big debate in 2016, to highlight the need for reform and policy reform in drugs.
Thank you very much. Our next speaker is Andrey Klepikov. From he is the executive director of the HIV/AIDS Alliance in the Ukraine.
Hello. Our region, Eastern Europe and Central Asia, is facing a growing epidemic, HIV epidemic, and it's driven by injecting drug use. Predominantly two countries, Russia and Ukraine, are accountable for over 90% of all new cases. But these are different epidemics. They are both driven by injecting drug use. But one is going up in Russia and another is going down in Ukraine. Why? Because of the application of scientific approach. Yes, in area of health, in area of response to drug use, there is also scientific response. It's called harm reduction. It's called methadone-based opioid substitution therapy. But science provides a solution, but not the ultimate one. Because ultimately, science is facing policy. Policy sometimes which is driven by ideology, which is driven by business, which is driven by prejudice. And in Ukraine and in Russia, we have these clashes actually. In Crimea, the situation we all know, where we are facing not only political intervention, military intervention, but actually terrible outcomes for the health, for the citizens. For them, services were cut. 14,000 drug users were not able to access to sterile injection equipment. And 800 patients of methadone-based substitution therapy were completely cut off the services. This is called torture, when essential medical services are not longer available overnight. And 20 people out of this 800 already died. Now died. In these days, yeah, we are civilized countries, but we are not facing civilized situations due to clashes of policies. This is one example how important for science to be hot. Our session is called Hot Science, and we meant hot debates, discussion. It's even goes beyond this, because in Crimea, hot means war. Hot means killing people. And this is consequences of the policies we have. So science should be able to defend its position, to be able to impose scientific position versus ignorance and violence. Thank you.
Thank you very much. Our next speaker is Archil Talakvadke, who is the Deputy Minister of Corrections in Georgia.
Thank you. Good afternoon, ladies and gentlemen. For the government of Georgia, it's a great honor to be part of this Euroscience Forum. And of course, we have something to say to add to the value the German presenting this afternoon. Georgia is currently balancing its drug policy between primary health care and law enforcement, and developing capacity of harm reduction, developing of capacity of public health healthcare interventions. Georgia's example is how actually neglecting public health priority led to overcrowding of prisons. Georgia had one of the top imprisonment rates in the world, and how actually neglection of public health priority damaged integrity, and economists of the families paying high price for zero tolerance, paying fines, paying bails for their family members, not getting real aid and a solution to the problem. And Georgia's example is actually how the repressive approach lets spread of infections out of control. And I think Georgia is nowadays an emerging example of dialogue between government and civil society, science arguments and political arguments. And in particular, prison healthcare reform completed during the last 2 years actually demonstrated that its results create even more room for widening the reform and for rethink the existing policy, which actually damaged public health and made actually morbidity and mortality data very damaging in the prison settings. Now this approach is being changed, and we are witnessing how actually morbidity data improves, how mortality decreases, how the country is avoiding the last 2 years overcrowding of the prisons, and how actually investment in the harm reductions brings reward and profit to the country and to the general population.
Thank you very much. Wilson Compton, is the Deputy Director General of the National Institute on Drug Abuse in the US.
Well, thank you very much. I think it's important to realize that drug addiction and the harms related to drug addiction are a public health crisis. We're seeing this in many of the examples from Eastern Europe that you've just heard described. We heard a success story out of Scotland. I would point out to you a new crisis we're experiencing in the US around overdose. The overdose epidemic related to opioids continues to increase. The latest data shows that overdoses are more common in the US than car accidents as a cause of death for our population. So what are we doing about it? Well, we've taken a multifaceted approach because we can use science to help drive these policies. So we can look at what are the prescription policies that seem to be underlying that in terms of the excess availability of opioids generally. What are we doing in terms of direct interventions to reduce the overdose mortality by distributing naloxone, which is an overdose intervention. It's a way to resuscitate somebody who's blue and not breathing. So if we can provide that on the spot through first responders, whether that's police themselves or through emergency medical personnel or other drug users having access to these life-saving medications, we think we can turn this around. Fundamentally, the NIH has been supporting research in this area to embed addiction services in the health system as an alternative to seeing it purely as a criminal justice. I would suggest that it is the combination of health and justice strategies that show the most promise, given the underlying nature of addictive diseases.
Thank you very much, all the speakers. Can I just remind you that we've only got about 25 minutes for questions, but any of you who want to pursue individual interviews can do so in the overflow room afterwards if the speakers will permit. Thank you very much, if you will. And who wishes to? Okay, Dominique.
I would like to ask a general question to Michel. Sorry. Dominique Leglu, Sciences et Avenir. I would like to ask you a question about Europe. You would consider how many people are concerned by drug addiction? Do you have a percentage of the population?
Yes, the estimates are that around 1 million people are injecting drugs in Europe.
More or less, could be 2, could be...
These are surveys. There is an observatory. There are two sources of data. One is what governments report, and the other are surveys. So it's plus or minus 300,000.
Questioner here. Can you state your name and affiliation as well?
My name is Anne Nolan. I'm writing here for Science Foundation Ireland, but actually I'm from Trinity College Dublin and a technical specialist in HIV. And I'm just interested, I'm not clear what the panel's position is and what you're actually advocating. Is it harm reduction for 2016 or the decriminalisation of drugs and greater regulation of drug policy from the European position? And I'm just interested to hear what you know, how you think that is going to be achieved in the next 2 years. I mean, you know, the war on drugs rhetoric has dominated, as you've all already said, for a last number of decades. And Jean-Paul Juncker is on record as saying, we all know what we need to do as politicians. The problem is how to get re-elected once you say it. And we all know the case, Professor Robertson, of David Nutt in the UK, who basically presented the position and the evidence to the UK Advisory Council and was subsequently fired for his troubles. So, you know, how do we get politicians around the table and actually listening to the evidence and removing the value system that basically primarily underscores drug policy?
That boils down to one very big question, which I think all of the speakers might wish to answer. So.
Thank you. I'll go first, and this is personal. I mean, I'm not expressing here the views of the United Nations, except to say that the Secretary General has called on what he calls a very open debate where no options should be left out. That's very clear. Personally, I think I'm advocating for prioritizing health within drug policies. Second, ending criminalization of use or of possession without any intent to sell. And third, for experimenting forms of regulation and legalization, as we're now witnessing for cannabis in Uruguay or in Colorado States or in Washington. How can we achieve that? I don't know. What we have already achieved, and this particular seminar and this press conference is demonstrating it, is that the debate has been open. It's been closed, and it's closed in Europe. And politicians do not want to open it in Europe. So first step, we've opened the debate. Second step, we will advocate as much as we can, and we'll see what happens. But big political fights are ahead of us at that General Assembly in 2016.
Thank you. Professor Robertson?
Well, it's a difficult question, isn't it? I mean, it's almost impossible to answer. But I mean, things that spring to mind are just the sort of examples. I mean, people often work on case histories and countries and states and individual areas that reinterpret legislation, and it does. I mean, I'm aware that in the UK, for example, we have a pretty hostile approach towards interpretation of the existing United Nations regulations. So, if I pass drugs to my friend here, then I'm committing a criminal act. In Spain, that's different. I mean, it isn't a criminal act. So there is different interpretations. So I don't think. I mean, I think it's down to the United Nations to lead on this. But I mean, domestic governments can do a lot as well. They can interpret things, and I think the changes that have happened in Uruguay and things that have happened in the United States are really interesting case studies, aren't they? I mean, our own case study of trying to change cannabis from Class B to Class C within our own Misuse of Drugs Act was a disaster, and a political disaster, because before the election, before the general election, exactly as you say, the politicians panicked, and I think it was driven a lot by misinformation through the media and through public debate, which was completely. I mean, all that legislation or reinterpretation of the legislation did was to say we wouldn't put people in jail for 10 years for possessing a bit of cannabis, which seemed pretty fundamentally sensible to me. But it got thrown out, and it was so. But you do need the wind of change behind you, and I think that's what's important now. I mean, if the direction of travel is changed from the centre, then domestic governments do get the idea and can make changes. And I think we can hope for all sorts of possibilities, and it turns up all over the place. It turns up in how you approach health and how you approach incarceration, and all sorts of things need to be reinterpreted. But I mean, I think, like Michel, the biggest thing for me is that health has to take a lead, and for me, it isn't psychiatry any longer. It's general medicine. It's everybody's responsibility. It's no longer a specialist topic for psychiatry. It's always been the lead specialty, but they've struggled, I think.
Thank you very much. Andrey Klepikov?
Well, in our context, we already saw how changes in the policy can be positively perceived by society. For example, decriminalization of drug use is still on the way, but some of the practices already has been applied. Like, according to the legislation, there should be criminal offense up to 3 years imprisonment, even for having small quantities of the drug. So even social worker carrying, for example, 10 used syringes can be stopped by the police and sentenced up to 3 years. We still have this on paper, but it's not applied, and we already saw positive changes, and maybe it's also one of the ways that things cannot be changed overnight, but when police officers and society and politicians see that basically there is no sense to apply such policies, it can be turned even initially unpopular political decision into reasonable and supported by society.
Right, Archil.
Thank you very much for your question. I would say that our example actually proves that drug regulations can't be considered separately from from harm reduction and public health response. I think that the legal framework should create positive environment for harm reduction, because in Georgia, for instance, we've seen that we had actually harm reduction programs in place. Also, simultaneously we had very harsh actually drug policy punishing consumers and punishing the person who possessed a small amount for the sake of actually personal use. And we had a legal framework which somehow hindered the implementation of harm reduction services, because the beneficiaries of the harm reduction programs were protected. So I think that if government based on our example, actually, the government which wants to change the developments towards positive must think for changing both, balancing both, so that legal framework helps somehow implementation of public health response.
Thank you very much. Dr. Compton.
I'd just like to add, you asked how can we influence these changes? It's important to recognize that change happens often when there's a crisis. We're seeing in the US a crisis with over-incarceration and the economic downturn. We can't afford to incarcerate so many individuals, let alone questioning whether it's effective or not. The data around the effectiveness has been available for some time. So that what we're seeing now is as it sort of goes together with the economic issue, there's an opportunity to think through some innovative new strategies. That's where science can play a role. When some of the new approaches are truly innovative, that's what makes a good scientific project and a good chance to drive the policy with new, strong evidence.
Questioner at the end.
Yes, regarding Christoph Behrens, Süddeutsche Zeitung. Regarding the crisis, we've seen drug use rise, especially in southern European countries like Greece. So does the economic crisis actually worsen the drug problem, or can it also be a driver force for policy change?
Roy, you should take this one. Yes, the answer is yes.
Yeah, that's right. The answer is yeah. I think absolutely. I mean, I think if you take your eye off things for a minute and things go wrong again. And I think harm minimization depends upon a consistent and a long-term strategy and a change of perspective. I mean, the paradigm has to change, and this is when you're dealing with a sort of public health thing like, I mean, it's the same with other examples of public health, tuberculosis or, any anthrax or anything. If you stop providing your basic prevention measures, you don't check food properly for infection, then you'll have problems. And as soon as, the example of Greece, as soon as your public health system stops providing injecting equipment or support for drug users, you get a little epidemic of HIV infection. And I don't think people really realize just what sort of a major world crisis there is with HIV infection just now. In Europe, I think we feel quite cozy. We feel, and in the UK, people constantly say to me, well, there isn't a problem in drug users with HIV. And I say, yes, but, there's millions of people out there, with a massive problem. And, not only are we interacting with the rest of the world, but as soon as we reduce funding for prevention services, things could very rapidly go out of control. And when epidemics happen amongst injecting drug users, they happen quickly. They happen within a space of 12 months to a year. You can get an epidemic amongst a population of drug users. But the population of drug users in the Far East, in China, in Russia, who are infected with HIV infection is just staggering. I mean, I'm not sure that people really understand. This is an African-style epidemic of HIV driven by drug injecting. So it's a new perspective. And of course, in Africa, I mean, we always think of it as a heterosexual disease, but in Kenya and Tanzania and South Africa, injecting drug use is driving the HIV epidemic again.
Just to add on that, if I may, another example in Europe is Romania. In Romania, harm reduction programs were implemented by civil society organizations funded with international funding, and particularly the Global Fund to fight AIDS, TB, and malaria. When Romania entered the EU, 2010, Romania became no more eligible to funding from the Global Fund. The programs dropped. Civil society organizations had to close. For about 5-6 years, the injecting drug users accounted for about 5% only of new infections in Romania between 2005 and 2010. That figure raised to 42% in 2011 and 61% in 2012. So this is the answer to your question, and a comment on what Roy was saying, that it takes very little to actually have an explosive epidemic. And let me also say, Aiden was asking me to give you a few figures. Overall, it's estimated worldwide that there are 16 million people injecting drugs. Of these, at least 1 in 5 is infected with HIV, and 2 out of 3 are infected with hepatitis. And in people who are infected with HIV and drug users, co-infection with hepatitis is extremely high. Andrey gave a figure of basically 90% in Eastern Europe. That's true for Ukraine and for Russia.
Would any other like to add to that? If not, is there a question up? Father.
Broadly, in response to what all the speakers say, I think it's more to do with political decision making and administrative decision making than science itself offering solutions to the problem of drugs. Let's assume that you come out with innovative solutions. Is the political leadership or a group that is sustaining itself economically, politically, socially on drugs, will they let go? For instance, if you take in India, there's a widespread bribery system which works from the constable right up to the police commissioner in crime. So you may have a solution, but the system will not want to change because I think drugs is channeling thousands and millions of rupees. And of course, in Afghanistan and border countries like Russia and then Pakistan. So money making is the primary motive. So I don't know, until you break that one, how would an innovative solution work?
Could I, in a word, can I say that science has the answers but not the solution? It's politics that has the solution. That's the point you want to make, yes.
Well, I would somehow certainly agree with you, and I'd ask Andrey to say something he said earlier about some of the interests behind it. But let me say, if you ask the question, why is it that politicians don't move on this? First, because it looks good for a politician to look tough. Second, because those politicians who would appear as soft on drugs somehow, currently in the public opinion climate would take a very high risk. Third, because as you say, there are lots of interests behind this, which were implicit to your questions. But let me just go to what I would think the solution. And again, I'm speaking here personally, or let me be clear, not as with my UN mandate, but as a member of what's called the Global Commission on Drug Policy, a global commission of 20 people, chaired by former President of Brazil, Cardoso, that has people like Kofi Annan and at least 10 previous heads of states in that commission. Our position is, the answer to your question is, regulate and legalize drugs so that governments are back into control. As we go on with a prohibition system, we just generate the illegal market and the corruption and everything you're saying. So bring back government in control, and that can only happen through regulation and legalization.
I would like to add also Yeah, as we discussed at the session, that there are some not only ideological interests but also business interests to maintain illegal drug business. And we calculated the losses for illegal drug business from our Ukrainian experience when we put 8,500 patients on substitution therapy, methadone-based substitution therapy. So basically we took them away from the criminal environment to medical institutions. What are the losses? Math is very, very simple. So drug user spends $10 per day per drugs. So multiply by 365 days and per 8,500 patients. It will result in $31 million per year in Ukraine. And we are talking about 8,500 patients. You know the estimations how many drug users live in Russia? 3 million. So the losses for methadone program from illegal business will be billions of dollars. So that's why you see how strong politically, which is the top of the pyramid, Russian policy is so repressive and doesn't allow any of the patients to be taken away from the criminal environment. Any of the patients taken on methadone-based therapy.
Did you want to add, Roy? Wilson?
I hope we can take advantage of some of these social and legal experiments that are ongoing internationally and currently in the United States. We're certainly investing heavily in research to look at what will happen in Colorado and Washington, as well as a larger number of states that have legalized marijuana for so-called medical purposes. These provide some opportunities to learn. There is a great risk of expanded use of these substances as you lend commercial enterprises to habit-forming and pleasurable substances. We certainly don't see the alcohol and tobacco industry and the tobacco fields as good examples of how we've been able to regulate and prevent harms. When you look at the amount of health damage from alcohol consumption, it is astounding. When we look at the amount of mortality from tobacco, 100 million lives lost in the last century and about 1 billion estimated to be lost in the 21st century. I'm not sure that unleashing a new commercial product in the addiction spectrum is necessarily a safe thing. So this is why I'm grateful that we have the opportunity to learn from some of these examples currently underway. And that's what I'm going to help try to support as a science administrator, is research to look at these changing policies.
Thank you very much. Notionally, we have run out of time, so I'm going to close the press conference. But I'm going to ask the speakers if they will consent to talk to you individually, because I know some of you will actually have some quite close questioning. What we've heard has actually indeed been quite startling, and I'm grateful to the speakers. Thank you very much indeed. And our next press conference is 2:00.